My patient is quite young, is hypertensive, not diabetic, ECG was normal. Echo show LVH, good LV functional patient with stable coronary artery disease admitted for coronary and diagnostic coronary angiography. As you see in the left system, there is no critical stenosis, only mild lesions in the ostial circle and the LAD. And this is the first shot of the RCA. It is faint, there is no backflash. So the operator at that time, he think he have to go forcefully and inject the dye to this RCA to be more clear. And see what happened. This is the bad news. This is very horrible catheter-induced dissection in the RCA. And if you see the backflash of the injection, even the left system appear. So the operator at that time forcefully inject the dye into the RCA and with this. And this is diagnostic catheter. So the patient, without any delay, the patient developed acute inferior MI with complete heart block and severe hypotension. The temporary pacemaker inserted to ensure the pacing and the rhythm. And if you can see here, the RCA now is totally occluded. As Dr. Musa Akbar, the key here, first point is from choosing the guiding catheter, the most softest one. The second point is don't go for the same side of the engagement. Be away from the RCA ostium, trying to sniping the entry point to the true lumen. See here, we have big hematoma, subintimal. There is a big flap. We have temporary pacemaker, and non-selective engaging by the guiding catheter, and you have a wire in the false lumen repeatedly. What you can do for this patient? Now the patient life is threatened. You have to notify your surgeon and try by the most softest guide wire to get in. A lot of trial, and the last one succeed. And this is the good news. The wire pass away from the entry point and pass into an RV branch. This is very good news. So we pass the wire distally and inflate small balloon to enlarge the true lumen. And we took another wire, soft wire. Can we pass it easily to the, we didn't use the IVAS at this point, although it is essential, but the life of the patient is threatened now, and we have to be in hurry to save the life of the patient. And if you look here, the wire pass into the posterolateral branch. So we are 100%, we are inside the lumen. So we start stenting from the distal, and we localize, as you see, localize the dissection flap from the position of the previous wire. Here, this is the end of the dissection flap. It ends after the posterolateral. So we put the stent in the PDA, and this is the first stent. And we protect our posterolateral branch. We pull the wire. We continue stenting to the ostium. This is the last one. And we push the wire again, and it is passed easily to our posterolateral big branch. Pass easily, and this is what the result. Now we have telemetry flow in the PDA. The sinus rhythm return back again, but we have a problem in the VLV. Should we continue and go for stenting, or should we stop here? As far as the patient stable, the blood pressure return back to normal, and the pacemaker non-functioning, and the patient return back to sinus rhythm. If you see, the posterolateral is very big branch, and the flow is around TIMI1 flow. Should we leave it, or should we take the patient out, or should we stent? You have to stop. So my decision was not. I continue the procedure with inverted kilot. This is my stent, this is the kissing, and this is the final port, and this is the final result. So we started with this, a cold, horrible beginning with the horrible dissection and the acute inferior STEMI with shock and complete heart block, and end with this TIMI3 flow in all the vessel, and thanks a lot. The key message here, you have a diagnostic catheter and you have a dissection. and the time it taken about 2 minutes to exchange it, and we lost the RCA. So you can pass the wire through the diagnostic and ensure you have something inside the lumen, and take another access to get to easily to pass to the true lumen. And this is the message from this case, and thanks a lot.